So let's go.
Sorry.
Yes, Rishikesh, we can start now.
Yeah, I'm getting my slides on.
Okay.
So I welcome everyone on to episode 3 of Scalpels Society, What is Obstetric Care Like in Rural India? We have Lalitha and Regi George from Tribal Health Sittilingi. G and Ta, as we are used to calling them and as they prefer to be called, we are going to trace through their journey and I'll give a brief introduction about Tribal Health Sittilingi. This is a Rudolf Virchow quote, which says that the physicians are the natural attorneys of the poor and social problems should be largely solved by them. I think G and Ta are a perfect embodiment of this, where they have fought or they have worked continually towards not just providing health, but also working towards social determinants and the problems that the community they have chosen to work with face, and have continued to push on to improve the indicators there. A general disclaimer that this talk is titled What is Obstetric Care Like in Rural India, and we will be touching on it, but we'll also be talking about rural health in general and about the work of tribal health section. So Ikigai is a Japanese concept, and this is the Western interpretation of it, where it is the intersection of what we love, what the world needs, what we are good at, and what is financially sustainable. And I believe that for G and Ta, the foundation that they have begun is their Ikigai. This is the single-room thatched hut that the villagers built for them back in 1993 when they decided to set base in the Sittilingi Valley. At that time, this was 100 kilometers from the nearest phone booth. The Sittilingi Valley consisted of 16 villages that they targeted to serve initially. And among these 16 villages, there were a total of 10 two-wheelers. And sick patients were usually brought on bullock carts or one of the two tractors that were available at that time. The nearest sub-center was Harur, which was just a OPD function. And the next nearest surgical capable center was Dharmapuri or Salem, which was 100 to 120 kilometers away. So this is the transformation from 1993 to 2016 and now presently. We see so G and Ta post their MBBS have worked around a lot of places. They have worked in Gandhigram in Tamil Nadu, and G has trained in anesthesia, and Ta has done her residency in obstetrics and gynecology. And G has also worked under a surgeon and practiced for a surgeon as almost 2 years, after which he decided to go ahead with anesthesia. So with this cumulative anesthesia, surgery and obstetrics and gynecology, they set up in 1993. They aimed to serve people that were furthest from the nearest health setup, and they aimed initially to, from the beginning, to work with social determinants. The ideals of setting up Sittilingi were based upon the Alma Ata Declaration, and we'll touch base more upon it as we talk with G and Ta. And over time, these are the domains that Tribal Health Sittilingi has worked on. For health, it has been the hospital, which is now a 40-bedded hospital, secondary level hospital with fully functional operation theatre with advanced operative capabilities, and also community-based healthcare initiatives where women from the society have been actively involved in treating. It started off initially with treating malnutrition, diarrheal diseases, and respiratory illnesses, and we'll discuss the effects of what that community involvement has been. On the economic ground, as other social determinants of health, they have worked on organic farming. They have motivated farmers to abandon the intermediate chemical-based farming and switch to organic farming. And processed finished products or processed grains have also been supplied on by SOFA, the Sittilingi Organic Farmers Association, and SWAG, which is their food processing unit. Tribal art has also been supported by the Porgai Artisans Association. The Lambadi community, which has migrated from Rajasthan about a century ago, they were losing their handicraft tradition, that they were a handicraft tradition, and with the assistance of the THI, they have refound their art and are now producing and supplying their artisanal handicraft across India. Along with this, THI has also worked on local governance and after-school education, and is also currently is actively working on sensitization of youth across India and medical colleges with the rural sensitization programs. A lot of people that are involved right now on the meeting can also check these out for continued exposure to rural health. So impact that tribal health Sittilingi has had over the years is that when they started off, they chose Sittilingi for their poor infant mortality rate and other healthcare indicators. It was 147 per 1,000 live births when they set it up, and now it has been reduced to less than 20. As a marker, the SDG goal by 2030 has been under 25. India has almost achieved the goal at the national level on average, and Tamil Nadu is also within 15 infant mortality rates. In the years that they have been there, I believe there has been no maternal mortality in the area, and economic. There has been no malnutrition, and there has been economic sustainability, and also impact in local governance has helped them to be more involved in their own community. So I would like to start off by asking G and Tav what their inspiration has been on what led them to set up base in Sittilingi, and how the declaration of Alma-Ata has been an active inspiration, not just from a long answer question in MBBS to actually seeing it for what it is.
Yeah. So we have a lot of insects coming in. We'll just put the light off. Okay. So what are the questions? Sorry. I was just adjusting the light. Can you, Regi, tell me the questions here?
Yeah. What was the inspiration to set up base in Sittilingi, and how did you come about initiating it?
Is it?
Okay, I'll talk about, because since you mentioned Alma-Ata, yes, we were inspired by the Alma-Ata declaration. We are still, and we will always be inspired. Because I think that anyone who understands health in its full meaning, the way WHO defines it, and anyone who aspires for that kind of health for all the people of the world will naturally be inspired by the Alma-Ata declaration. Because in my understanding, there has never been such a revolutionary and politically charged document ever on health. It includes all the people of the world, and its foundation is in an equity-oriented approach. It stresses on the need for a comprehensive strategy to provide basic health services for all, but also addresses the underlying social, political, and economic causes of poor health. It links health to a participatory strategy, which was later called as a people-oriented approach to development. According to its support documents, the support documents of Alma-Ata, the purpose of development is to permit people to lead an economically productive and socially satisfying lives. Primary health care is essential for allowing an acceptable level of health so that people can contribute to their own social and economic development. So these documents emphasize that health for all will require a structural change in the direction of greater socio-economic equity. So the proper application of primary health care will have far-reaching consequences, not only throughout the health sector, but also for other social and economic sectors at community level. So it will influence community organization in general. So there are many who say that it was tried and failed, what Almata talked about. But in truth, at least in India, it has never been tried, certainly not on a large scale, in the comprehensive form as advocated in Almata. So it is very natural that we wanted to try, some of it at a micro level. Yeah. We also asked about the
So one of the inspirations is before we worked in Sittilingi, we were working in a place called Gandhigram, and we were working as doctors. I was full time with PFH because I was either doing surgery or anesthesia, and I was in the neighborhood. But one of the things we realized is that, the 5 years we worked there, we realized that this is not the answer to healthcare. So unless the people know how to look after themselves, we will never. I mean, it's an endless thing. We can just keep on doing services and people stay coming back. And therefore, Sittilingi was and is still an experiment in progress, because we wanted to see whether people could look after themselves, and that's how Sittilingi started.
What made you choose triangulate upon Sittilingi in the first place? What was so special about it?
Yeah, so we, since we were in Tamil Nadu already while we were working Gandhigram, so we wanted to, G did a 1 year travel before we came to Sittilingi to many remote areas in India. And during that 1 year, we realized the tribal areas all over India are in very geographically isolated places, where the borders of states or borders of districts. So we decided at the end of the travel that we would like to work in a tribal area. And because we were already in Tamil Nadu, we were looking at the health statistics of tribal areas in Tamil Nadu and shortlisted 3 places which were furthest from a healthcare facility. And Sittilingi happened to be one of them. So we thought we will go to all these 3 places and listen to the people and decide. We came here first. We listened to the people and we stayed on. So that is the reason for selecting Sittilingi.
Can you talk about your early days of when the villagers built that thatched hut, which was just 1 room, and how you initiated the services there?
These are early days. The villagers built that. Okay, so we came here from Gandhigram. We had no money, so we could not buy land. We didn't have the money to buy land, so we just encroached on 1 acre of land.
Government land.
On government land, which the hospital is still now, and it's still under lease. We don't own that land. And when we got around with the people and started talking to them, they agreed to build us a small mud and thatch hut. They provided the labor. It was a mud and thatch hut, so it was not very difficult. They went to the forest, cut the wood for the roof. They donated grass. They were thatched with grass. So it was just built like that. Early days were very tough because we hardly had anything. So we knew the treatment, but we didn't have things to treat it. And because we did not have funds in the beginning, we had just a very limited amount of medicines which we bought, a few surgical instruments, with the thought that okay, we may have to just do an IND and this thing and all. But finally, we ended up doing much more than INDs. But anyway, that was what we had with us: a 100-watt bulb, a wooden bench.
No electricity.
Yeah.
It was a solar
First
lantern
year,
initially. First 2 years was just solar lantern.
Then when we got electricity, it was just one 100-watt bulb and one wooden bench. Deliveries were on the floor, and you can actually do pretty much in a small one-room hut because we used to put chest tubes, all sorts of things we used to do with just that. Thiopentone was the anesthesia we had, and an ambu bag. With that, you can manage a lot of things. Ketamine. So a lot of anesthesia can be covered with that. So that was it. And the people were hardy, so you don't have to use too many antibiotics now. They would come out. The big problem was malnutrition and maternal. These are the big problems. And transport. Because, see, when we came here, there was only one road coming here and it had no bridges. So during the monsoons, we are completely cut off. We can't go outside, nobody can come inside. So getting provisions, getting material, all was a big problem, including getting IV fluids. And we had no vehicle, okay, so we had just one bike and that was what we transported, all our stuff.
So, what all procedures you mentioned that deliveries were being conducted? How did the surgical setup, what surgeries did you start off with, and how did it progress along the years?
Actually, big surgery started only after 3 years we got some funds to build the 10-bedded hospital. Then we had a small operation theatre. I mean, so the total amount for the building and equipment was 2.75 lakhs. So you know how much we can do with that. So we just had a small steel table where you could, raise the head end and do a lithotomy. That was the operation theatre. We had a 100-watt bulb. We had just an EMF apparatus. We didn't have this thing. And ether. No oxygen, no boils apparatus, nothing else. Just ambu bag and things. But it's surprising again what all things you can do with that, because we were doing all emergencies, including abdominal emergencies, perforations, obstetric hernias, intestines, rupture uterus, all sorts of things we were doing, rupture ectopic. So, actually, if you have the will, you don't need much things. I mean, you can do it. And oftentimes, there are so many cesarean sections we have done at the top stage. It was just so normal that we just got used to doing that. So, that is how we do. There's no baby resuscitation. Baby resuscitation was on the floor. So you will take the deliver the baby out of the abdomen and then lay it out on the floor. There's a 100-watt bulb. That was a heating. And that's how we manage. And eclampsia, what else? I mean, all sorts of things. Yeah.
Now, can you talk a little more about how eclampsia, pre-eclampsia was managed at the center?
We had pre-eclampsia, but then we had a very vibrant community health program from 1998 onwards. So women in the mothers in the valley, we were able to manage pre-eclampsia, and prevent eclampsia to some extent. But we still got quite a lot of eclampsia during that time, because either from outside the valley, where we didn't have the community health program, or even mothers from the valley, but they are not staying in the valley. They will be outside somewhere as migrant laborers in some city without any antenatal care, and then finally end up come here when there is a problem. So we used to get, and then that was before the days of magnesium sulfate. So at that time, now we used to manage eclampsia with the Menon's regime. It was pethidine, chlorpromazine, and promethazine. A cocktail of this was the treatment for the eclampsia then. So it was really difficult because pethidine was not available. We didn't have the license for pethidine. So we had to do Menon's regime without pethidine. No, it was not complete. And it was very difficult managing that. And we can't hydrate. So we can't orally, because they'll be so sedated that we can't orally hydrate mothers. No, so it has to be IV fluid. And then the problem of pulmonary edema is there. No, so we have to hydrate, but we can't hydrate. No, so it was quite a tough time. And then that early years, we have lost a mother due to eclampsia also. No, she developed pulmonary edema. Early years, not from the valley, but some other village, and they came, and then we told them to go somewhere else where she had only her mother with her, and they wouldn't go. So those were the times. No, but we managed to so many days and nights. Our senior health workers and I have stayed with. Literally, stayed awake with the mothers, to see them through. And but then magnesium sulfate came and it revolutionized the management of eclampsia, and even also pre-eclampsia. So I think that came down, the incidence of PIH and eclampsia. I don't know how it is now. I'm not directly involved with labor room nowadays. No, I don't know how is the incidence now. But then it was really tough early days, but we managed.
And what about postpartum hemorrhage and immediate postpartum complications that had to be managed surgically?
Postpartum hemorrhage, like it was not that much. I think we have the whole management of labor with so much care. That is something which I learned after coming to Sittilingi. You do the right things at the right time, and be with the mother. Actually, the complications are, and give a focused care, which we are able to, and we still do. It was the complications were less. Compared to my time in Gandhigram or when I studied in LP in Trivandrum, I know considering that labor room, the complications were definitely less here. I think the only thing that I can contribute is the three things maybe. One is the immunity, the resistance, or the willpower of the people, the mothers, and then our obstetric decisions were not strict obstetric decisions. They were also social decisions, discussing with the parents. And I think a lot of that also contributed to what it is, how the labor or the post-labor they turned out. And also our care. So the complications were less. So we didn't have to manage anyone with surgically with a postpartum hemorrhage, doing a laparotomy or hysterectomy or something like that. But we could manage otherwise. We didn't have blood. Blood is 120 kilometers away, blood bank. So later it became, a new road came and it came closer. But we have managed. We have also managed in the heart you saw. We have managed acute inversion uterus. In the early days, when we had just 2 artery forceps and 1 scissors and no oxygen. But suddenly, first time I was seeing one. I only learned about it. But suddenly, she collapsed. Spontaneous acute inversion. Suddenly water coming from blood coming as if water is coming from a pump set or something like that. That kind of, and suddenly she collapsed. But luckily we had the anesthetist with me, and then we had thiopentone sodium. So, but the thing is that after managing it, then seeing through, sitting with the mother, day in and day, night and day, for days together, till her pulse rate comes down, and because we didn't have anything else, and they wouldn't go anywhere. So we just have to be there now anxiously, till she comes out.
Yeah, and there was also smuggled blood bags also. So that was the time when we could get it easily. And we got it from Delhi, then Goodlow used to help us, then JSS used to help us with smuggled blood bags. So we would always bleed relatives or bleed the staff and then replace blood. So that was the other thing we did.
At that time. That is how rural hospitals manage.
It's really inspiring. When I talked with Tab previously, this 2 artery forceps and 1 scissor days and 100-watt bulb and just an EMO machine. I think it is really remarkable of the things we can achieve managing acute inversion, ruptured uterus. So I think this has been a very central theme across their entire work of making best of the resources that are available. And I think one of the most beautiful things about this has also been how to maximize in utilization, like human resources, making the most, so helping people reach the maximum potential. So can we talk a little about how community engagement began and how the work along with the community has been?
Community engagement began. And
so other than the one thing was the community health program was going on. So we started off with an IMR of about 147. In 10 years, we got around 60. We were happy actually. But then we didn't know what to do because we knew that we had to also tackle the social determinants of health, and it was a term we heard for the first time. I think when it was updated. Because we are not community health people. And frankly, we didn't know what to do. So one of the bright ideas which came out during discussions was to just take a padayatra and walk from village to village and ask people tell us what to do. And said the people anyway know better than us, so let them tell. And so I think in 2004, when Ravi was one of our junior doctors, we sort of shut down the hospital for 3 days, and every 3 days we walk from village to village, sit down with people, talk to them, and said, tell us what your problems are and tell us how we can help you or how we can together do something. And a lot of problems came out. There are no roads, no schools, no ration shop, so many problems. But one of the biggest problems which came out was farming, saying that the only thing we know is farming and farming is at a loss. So can you help us with this? And we frankly didn't know anything about farming. So we learned, we went to organizations which were doing organic farming, asked them about this. We took our farmers there, they came here, and slowly the farming started. So in the beginning, nobody believed this, but then slowly they found that organic farming was profitable, and simultaneously we started about marketing roadways so that the produce here could be marketed. So that is one thing. So community engagement actually started with farming, and that is something which they could relate with, and they had no more knowledge than us. So they were actually teaching us, and we were learning. So that actually became quite big. Every year, so many people are joining, and even now, right now we have about 700 farmers. We go into the next 200, 900, and next year we're taking another 200. So it's growing very fast, basically because people are making a profit. And money is this thing. And with money comes a lot of other things, better education, better nutrition, better so many things. And the other thing is we stressed on was eating millets. So millet became a central point around which organic farming revolved, which meant people started eating millets. And then we found just eating millets and changing the nutrition of the community could tackle anemia and malnutrition, without even doing anything else. And we hardly have, very little antenatal mothers coming in with anemia, hardly any children with malnutrition. Some small grade, 1 grade, that's all we get, which was not the case when we came here. So the answer does not lie in a medical solution. It is a community solution, and it's food. And this is what many of the doctors don't realize. And once we realize that, and we realize how deeply economy and food affects the population, we started shifting a lot of focus into economy rather than medical things. And that's how Porge came in. Yeah, you can also go.
Yeah, so the answer to anemia and pregnancy is not iron for iron. Iron you have to supplement, that I agree, but that it is not iron fortified rice or anything. No, it's basically nutrition. No? Because you have to, like what they said in Almata, you have to work on what people grow and what people eat. Seriously. If we have to stop talking about anemia and pregnancy, even after how many years after 1947, we are still talking in all our conferences about anemia and pregnancy. It's a shame. So if we have to stop talking about it, then we have to work with the people and see what they are eating, what the mothers are eating.
Yeah, so Lalitha will tell you about, she'll tell you about, so Porge also came in as one of the feeders was economy, to build up the economy of this thing. Yeah.
So basically livelihoods, providing rural livelihoods and make sure that people can stay where they are, and do work on their land. Prevent migration definitely has a direct impact on health. So like when I work with the women in the livelihood sector, with the artisans or with the tailors, anyone, I don't think that I am doing something which a doctor should not be doing. So I feel that I am exactly doing what a doctor should be doing, because you are making people stay back in the villages so that they remain healthier, happier, and more dignified.
Yeah, so, and because we started working with farmers, when we got into some drought years, we started working on watershed. And that was in a Shramdan. So the villagers contributed to the labor, the hospital, everyone went. Every Sunday, all of us take up pickaxes, everything, and go and work with the villagers. And once water started coming in, we realized how important all of those things are. Water, instead of one crop, now you're getting two crops, it means you're doubling your income. So many things like that. And then that is when we understood the relevance of governance. That if you really want to do something absolutely concrete in the community, you should be able to govern that community. And so we started mobilizing people to attend Gram Sabhas, things like that, in a very democratic way. But the government naturally sabotages the whole thing. So then when the elections came, the people were already fired up. So they said, okay, let's stand for elections. And then Tribal Health Initiative supported it. And then we won the elections. And then we ran the panchayat for 5 years and found out how powerful running a panchayat is in relation to the health thing. Because after 5 years, one of our senior nurses called Madheshwari was our panchayat, sarpanch. And in 5 years, she saw that every village had roads, every village had water, every village had electricity, every ration shop was running properly, every school was functioning properly. I mean, that is what you call health, And that's how that engagement started. And after that, there are so much other things. We feel that unless we engage with the community, we cannot bring health into the community.
That was too long an answer for the question you asked. Sorry.
I think that is absolutely perfect. That is what we have all come here to listen to, these experiences and how it has been. So this has been something that is really, especially prominent now, that with medicine comes a very strong hierarchical model. So how has the calling everyone sir, ma'am, or just because of seniority or position. So how has the culture been different within tribal health initiative within DHI?
Yeah, so like you said, now the medical system itself and hospitally especially is very hierarchical, and we have always found that that is one wrong, unfair, and so it is wrong, and it is also unfair because in a hospital the major work, the soul of the hospital, I would say, are the nurses who are there, with the people who are sick always, 24 hours, they are the soul, but then you always give a it's the doctors are highlighted, and they are in the topmost in the hierarchy. So I always felt that it is unfair, and it doesn't work. It doesn't become a if you say in the right meaning of a team, it is not good. It has to be something different. So so that is why we have tried to reduce it. I wouldn't say that there is no hierarchy here in Sittilingi. There is hierarchy. Maybe it is less than in other places. So we have tried in all our because we have found out that especially when we did the community health program and health worker training and all that, we have learned so much more than anybody else, because all our trainings were participatory learning, and we have realized that I have, when we train the health auxiliaries and health workers and all that, I have learned a whole lot of things. My greatest learning was that I am so ignorant. After all that you study in your MBBS and your PG and come and then you are so ignorant about the people of the country. So little you know. So much we have learned from the people. So it is very natural that everybody is contributing towards each one's learning. So we have tried to work on that, reducing that hierarchy to some extent. But even without, even though people call me Ta and call Gigi, it doesn't mean that, everyone will come out openly and talk to us. Somebody who joined recently may call us G and Ta, but doesn't mean that that person will come now. So I'm not saying that it is there, but to some extent we have tried to reduce it. It helps. That definitely helps also.
We've seen this beautiful journey from healthcare and to across domains. What is the next project? We've moved on from, we have started dealing with more and more projects like Watershed came up now, and we've worked on food and nutrition. So what is the future of THI and the work continuing on in Sittilingi?
So we just started working in the Calvine Hills. The Calvine Hills, about 40% of our patients actually come from there. So hospital naturally gets crowded, and we have just 1 acre. We can't expand. Okay, there is nothing to expand. So one of the reasons why we said that instead of making the hospital bigger, let's build another hospital there, because it's much more convenient for the people. And Calvine Hills is huge. It's about 1,500 square kilometers, more than 1 lakh population. Not a single hospital, not a single MBBS doctor, nobody there. So we just started. We just bought some land. We put up a hospital there, and we put up an OPD there. It is full. It is all the facilities, so we do that. And hopefully, if things go well, it may also become another secondary hospital. That's in the future. So that is the next thing. And we now have a working model, like farming and economy and livelihoods and things on. Hopefully, we will be able to replicate it there. Our team is capable of doing that. Our team is actually quite well trained in livelihoods and this thing around. So for them, I'm quite sure they will be able to do it. So that is the next thing. Yeah.
We have also started working with the youth in a small way, mainly initiated by Tulir School, which our friend Anu, they are running. So starting, there's an initiative taken by them, by Tulir. So Tribals Initiative also participating in it, working with the youth on career counseling and also initiate them through sports into life skills and all that. Now, working with the younger people, which we have been talking about for a long time. That's a great need to work with adults and boys and girls. So that we have gradually started now.
What are it's been almost, I think, 30 to 33 years since the setup of THI. What have been the current challenges in obstetrics and anesthesia, but also still the pertinent challenges that still remain today?
Challenges now.
See, as society is changing, see, when you tackle one problem, you think that is over, and then another one comes up. There's a problem of also, for example, increased income brings in. So when you increase the income of a society, you are doing it without trying to also bring in equal moral support. So suddenly there's a new generation with money, and they don't know what to do with it. So there's bikes and the fancy phones and this thing, and naturally going out a lot for education, for work, etc. And coming back with those what we call non-tribal values, which is about making more money, making more things, and therefore a lot of things like I don't know, you get lays in the corner shop now, or fast foods, there's chili chicken joints everywhere. There's a lot of alcohol everywhere, which was not so much before. So these are the new health challenges you're going to face. So you get over malnutrition and infant mortality and maternal mortality, and you step into another phase, which is equally dangerous.
Yeah, so the earlier the challenges were smaller, and we could overcome those challenges with the community together. No? But then, as years go by, the challenges are bigger, and the enemy is more powerful. So there are certain things which are there. The government brought in a liquor shop in the valley. A lot of things like that. Were so many things which we are not able to fight against. Or the influence of media on the young people. Or also older people. So a lot of things. So if you ask me, and so some of these times we are helpless. We don't know what to do. So if you ask me, are we closer to health than in 1993 when we started as a community? I am not really sure whether we are closer to health. In some ways, maybe we are. But in certain other ways, we have moved backwards. So there are continuous challenges because the world is changing.
I think the function of a doctor is that every society will always have challenges. Is to be with them and try and help out in whatever challenges are coming. I mean, that's our function. The natural attorneys. We have to be the natural attorneys.
From my microscopic lens as a medical doctor, as we are a little indoctrinated to be, how has strictly the medical side of things changed over the years? How is the availability of blood since in these last 30 years, or the availability of surgical or obstetrical or anesthesia services there within the hospital or also outside of it over these years?
So that is naturally good. See, so both of us we knew how to do medical work and surgical work. But I think both of us had a very community mind. We were not trained like that, but we were. But when Regi came in and so Regi is also at MCH, okay? What is it? MPH. So he's a community medicine person also. I asked him, do you want to be in the hospital or do you want to be in the community? He said, I want to be in the hospital. So I told him, okay, I'll do everything possible to make you sick. So that's when we built an ICU, ventilators, that thing, all sorts of things. So in that way, we have actually gone far behind. I mean, far ahead. Now we have a blood storage center, so we have enough blood to do things, and then we are taking up much more challenging cases, and therefore people are seeking us out. We've got an excellent younger team, Ravi, Praveen, Aditya, a lot of young doctors who are, Rodney, want to do a lot of things, And so my function is to just keep on helping them to do, buying the equipment. So laparoscope, okay, buy the laparoscope and give them this or laparoscopic treatment. See, that is my mistakes. So definitely it has gone much. And now we have people from outside coming, urologists coming, spine surgeon coming. So there are a lot of happening things in the hospital, of which I am not too involved in. Neither is Lalitha. I is not also very much involved in. I mean, I occasionally go. It's not that I completely abandon them. I go when they call me. Okay, one surgeon is on leave, please come and do some surgery, I go. But otherwise, I don't go. I find it much more pleasant to go and sit in the community and work with the community. So, but definitely it has gone, the lab has, it's really modern, it's got all the latest equipment. So that way we've got a radiologist, so we have ultrasounds, and everything is there. So it's definitely advanced.
Or young aspirants like myself who are interested in working somewhere towards rural health, not having an exact idea. We are trained either at MBBS level or we have continued on and we still end up being confused. What advice would you like to give confused minds, or what are the different approaches that we can, continue working on towards betterment of rural health?
So, so I feel that it's like you are skilled, you have learned and you have been skilled. So I think when normally doctors think about what to do after you are finish your studies, is when they decide that, to think about the money, the working environment there, your colleagues, the learning atmosphere, all those things. I don't know how much the need of the people comes into the picture when you decide where to work. So I think that is a major thing which our country needs, to think about. I have these skills and I have this knowledge, but where is the need and how can I fit into that need? So that is a question. I think it will be so good if all young doctors think about that need. There's so many, just think about obstetrics. So many mothers in the country and so many areas where they need help. That is one thing. So I think if that can be thought about, it will be great. And the second, I say that wherever you go, work with the people. They know so much. So get them engaged, listen to them, and then so many answers will come from them. So that is something which we are not taught. So just listen to them, be with the people, and so that is those two things which I thought will be wonderful. If young people think about.
Yeah, and I think if you ask why THI is engaged with so much things, very diverse, it's not that we are smart people. We were dumb, and we were ready to go and listen to them and just take ideas from them. They will tell you what to do. You don't have to break your head on what to do. So you have to be ready to do. If you are going to work with people, even as a doctor, it's important that you go and sit with them and talk to them, and then things happen. So
Alicia has already posted it. If there are any other... Okay, Alicia has a question. If anyone else has a question, please feel free to type it out in the chat, in the message. What would your advice be? Like in the early days, you worked day and night monitoring patients, taking care of them and making sure that they can get back home well. What is your opinion or what's your advice about the newer generation like me who want more of a work-life balance, especially considering that we don't cope with burnout as well as we could?
So this is something which this question I am or this concept I am struggling with, because so for me, I didn't have, so whatever I got out of work were directly related to my life. So I don't know where my work ended and where my life began. There are people in the younger generation who have told me that you have not lived at all. You have only worked. But I don't agree with that. Because I feel that I had a very great life, so far. And work also has contributed quite a lot. So because if I am with a mother and listening to her, be with her family, I am learning so many things. I am becoming a better person as a person. Each day with each interaction. So I don't know where work ended and life began, but it depends upon how you define that. Which I am still not very clear. But burning out, if you burn out like that, then you will have to find mechanisms to tackle that. So on an individual basis, we'll have to find out.
Yeah, I'm just not very sure what do you mean by burnout? Is it a mental burnout or is it a physical burnout? The physical burnouts can happen. When you work 24 hours, you're really calm. But mentally, this is what I have felt. If you really enjoy your work, there's no mental burnout. I am just enjoying what I'm doing now. Do you ever get mental burnout by playing video games? You enjoy what you're doing, though. So how do you burn out with this thing? You can get physically burnt out. If you don't sleep, then you can, even playing video games, you can physically burn out. But if you really enjoy your work and like Ka said, if you really like being with patients and talking to them and comforting them and hearing their jokes and crying with them, and you're really enjoying it, I have never felt a mental burnout in that sense. Physically, yes, sometimes.
Asita is asking about what has helped keep you strong. I think G has already touched upon that by saying that enjoying the work you do. But also, when you set out in '93 to start Sittilingi, I think it was just the four of you. And over the years, what has been a support system to help you be mentally at peace and strong?
See, one of the things I wanted to tell all the younger doctors is, please have an interest which is not medical. It can be anything. It can be writing, reading, art, seeing movies, gardening, farming, running, gym, whatever it is. You have to have a certain amount of hours in your day where you can lose yourself in something else so that your mind clears up. And I think both of us have done that quite a lot. And also take breaks because this is what we told ourselves or comforted ourselves, is that Sittilingi is not going to, crash just because both of us took a vacation for 1 month. And so we used to, we both are trekkers, so we used to do a lot of trekking. And every 2 years we take 40 days off and trek. Do nothing else, trek. But it really kept our, cleared our minds and, relaxed us in this thing. So please have another interest. And if you have another interest where you can take your mind off whatever is happening in the hospital or whatever is happening in your life, then that really helps to make you mentally strong when you come back. And you will get able to think. If you're 24 hours in the hospital, you'll always be worrying about it. And so this is one thing. So please read, draw, sing, I don't know, play a musical instrument. Do whatever. And both of us, thumb pains, I found. So we manage. You're muted, Rishi.
Sorry. Yeah. It has been really inspiring. Across the other talks that I've also heard, I think Jayanta seem catalysts of change. I think they have a very innate. The credit is always to the community, and it is always a team effort, and they are always view themselves as just catalysts and not active. Not the change makers themselves. They are the ones that help people make changes to themselves. And I think their life journey has been extremely inspiring. Are there any any concluding remarks from your side? We have a session on innovations in rural surgery from Dr. Ravi from Sittilingi again. And we also have a question from Shweta. But yeah, if there are any remarks from your end, we can go ahead with that. Okay. Shweta's question is how have there been phases when your motivation to work has dropped, and what helped you come back?
My motivation has never dropped. So there always have been difficult times, but we know that it is temporary. There have been difficult times, but there have not been times where the motivation dropped. Never.
Motivation has not dropped, but actually, there are many times when you really get depressed. No funds, no money to pay tomorrow's salaries to staff. So these are these are people who have sacrificed their life for you. For this idea. And then tomorrow, when they want to pay bills, I don't have money to staff. It's depressing at that time. So those times are really challenging. Or you want to do something good and then the community says no. There are so many times the community says no. For the reasons of their own. And then you say, I am trying to do something good, and then now they don't want. But there's always some reason for it. So there are times when there are lows. But I don't know whether we lost our motivation. We ran off. We did.
Ranjita is asking about how you were able to mobilize funds and make this financially possible, and if there were any issues, political issues and backlash, and how you were able to deal with it.
Yeah. Mobilizing funds has been really difficult over the times, but we have now developed a mechanism because we don't depend on just one grant making agency. We have many small things. No one. So if one drops out, it still doesn't affect us. The other thing is about 25 years ago, we had husbands and friends of Sittilingi. We have this large group of well-wishers all over India, mostly India, but sometimes abroad also, who support us with funds. These are untied funds, and they come in every year, and we can do what we do. So that helps us to tide over. Because a lot of patients can't pay the bills, so it is right now. So where does the right of money come from? So that is how we mobilize our funds. Political issues, we have not had much. There have been small things in the villages, some small things, but nothing great. We don't have political parties who are. This is, I think, peculiar for the Tamil Nadu. Political parties actually appreciate good work. Whether it is now there is Vijay, but before it was ADMK and DMK, both of them appreciate good work, which is great. So they never touch. If you're doing good work and people speak highly of you, they don't touch you at all. So that has been a great advantage. I don't know whether it is the same in other states, but in Tamil Nadu it is. So we have not had any political issues.
And I think it has also been one of the factors might have been that all of this was actively community driven, and if you have the backing of the people that are around you, I think that makes it definitely much more easier.
Yes.
So, any concluding remarks from your side, Jiyanta?
No, thank you for inviting us. And so great to see so many people attending. I never expected that. It's so great to see so many people attending, and which means there are so many young surgeons waiting to burst out and do something great. So, thank you, everyone.
Thank you.
Thank you so much, Jiyanta. It was really inspiring to hear your story, and we all hope to find our way to Sittilingi and visit you soon.
Please.
And I'll hand over to Vibha for the next session, which is innovations in rural surgery.
Okay. Am I audible?
Yeah. Yes, you are.
Yeah.
Okay. So, good evening, everyone. Moving on to the special segment in today's session, which is on the innovations in the rural surgery. And this session is being conducted as part of one of the multiple activities commemorating the Global Surgery Day, which is being observed on the 25th of May every year. And a reminder that safe, accessible, and equitable surgical care is not a privilege, but a necessity for every community across the world. And it is truly inspiring that while much of the global health conversations happen in large institutions and urban centers, some of most meaningful innovations are emerging from remote and resource-limited settings, driven by the courage, compassion, and commitment to people often forgotten by mainstreams. So our session today focuses on exactly that spirit of innovation and service, and I would like to thank the IGS committee and the members who were there who had motivated us to organize this session. And we're deeply honored to welcome Dr. Ravi Kumar Manoharan, who will be speaking on innovations in the rural surgery and sharing experiences from surgical care in one of the most remote regions of India. He worked as a site fellow at the Tribal Health Initiative from 2017 to 19, and a rural surgeon by passion and practice. His journey reflects a clear commitment to community-centered healthcare. His life transformed after working with the unique tribal health program at Sittilingi, following which he pursued the public health studies in London to deepen his understanding of healthcare systems and equity. He later worked among tribal communities in central India, where malaria and tuberculosis posed enormous challenges, and subsequently completed the rural surgery training. Today, he had returned to Sittilingi, where he helps in managing a 30-bedded tribal hospital, while also mentoring and training young doctors who aspire to serve rural and underserved populations. His work reminds us that innovation is not always about expensive technology, and often it is about the adapting with empathy, solving problems creatively, and ensuring that no patient is denied care because of the geography or the resources. So we are grateful to have him with us this evening to share lessons from the ground, lessons in resilience, service systems, thinking, and human-centered care. On the behalf of URC and Innovations in Global Surgery, I extended a heartfelt welcome to Dr. Ravi Kumar Manoharan and to all participants joining us online today. Stage is all yours, Raviana. Welcome. You're not audible. Your mic is on mute, Raviana.
Yeah. Hi. Thank you. Can you hear me now?
Yeah.
Sorry. So thanks for having me here, and thank you for welcoming me, Vibha. I'll just share the screen here. I hope it's not going to be too much of Sittilingi today with following G and then me here. So just give me a second and just try this. Yeah, can you see my screen now?
Not now.
Is it okay now?
Yeah. Now we can see you.
Okay. So, I'll keep it. Hello?
Hello?
Hello, can you hear me? Suddenly I lost.
Yeah. No.
Okay.
We can hear you.
Okay. So I'll try and keep it short because it's already past one hour. So, so this is one favorite topic of ours. So people who know me probably must have heard thousands of times, and I hope you don't get bored again. So what is rural surgery? What does it mean? So we all know the latest advances that we have in surgery, like the robotic surgeries and the harmonic scalpels and all that. They're also surgical innovations, right? So what is it that is specific to rural surgery? What do we mean by rural surgical innovations? See, according to the Lancet Commission of Global Surgery, in 2026, they had mentioned that there are 160 million patients worldwide who are not able to receive surgery every year, either due to lack of money or lack of surgical facility. This is mostly in the low and middle income countries like India. So rural surgery innovations are those that have reduced the cost of surgeries without compromising on the quality of care. So that's what I would just put it in short. So Indian healthcare system, as we know, is heavily privatized, right? And most of the patients have to pay for their for the surgeries from their pocket. But the surgical community has somehow been made to believe that the expensive things means better quality. So I would like to differ here. It's like saying, say a Maruti car and Mercedes-Benz car have very similar engine and very similar features and all that, but just the branding or the packaging is so different that Maruti car sells for 5 lakh rupees and Mercedes-Benz sells for 50 lakh rupees, and people believe that Mercedes is better. It's just the brand. So this is how surgery practice in cities are going like. But if we can provide the same quality of surgical outcome at a fraction of a cost of these branded equivalents, that is what we would call surgical innovations. So let me start with a disclaimer here. So all the innovations that I'll be talking about or sharing here are not my innovations. Clearly, they are not my innovations, but they are innovations of many of my seniors, my colleagues, my mentors, and a few of them I have showed here, but there are a lot more, so many of them here who have been, amazing rural surgeons working in different parts of India and the world. So let me go to the first innovation that I would like to share about. So first thing is my favorite, the use of nylon mesh or so-called mosquito net mesh for hernia surgeries. So this is Dr. Tongonkar. He was a pioneer and was a strong advocate of nylon mesh for hernia surgeries. There have been several studies done and published in reputed journals also. But I am sure not many people in the surgical training now would have heard of this. I think any medical student or young surgeon coming to Sittilingi is still quite amazed by this idea, and I still I am amazed how they don't know about this. So we have been using this for more than 16 years, and we've not seen any increased risk of recurrence or complications. Actually, last year we did a quick follow-up of about 100 patients that we had operated 10 years back in 2014 and 15. And we could follow up almost up to 80% of the patients. And we found there was not even a single recurrence or infection or a chronic pain also. So it's saying that it's as good as any prolene mesh also. But the cost of this this mosquito net mesh is probably for us, we've not costed it, but I'm sure it's like less than 10 rupees, even including the autoclaving cost and everything. Whereas the prolene mesh would be easily 1,000 rupees, even the cheapest one. So I think the cost is like, no, it's obvious, so 100 times more. That is one thing for people to see. I would like to go to the next innovation here, which is the lift laparoscopy. This is Dr. Neandraj, who's been doing this, also called the gas insufflationless laparoscopic surgery for more than 15 years. He's actually developed this, and his team has actually fine-tuned this entire contracture to make it even more better now. So the advantages of these lift laparoscopic surgery is that it can be done under spinal anesthesia, which means in rural areas where we have a shortage of anesthetists very often, it can still be managed by a nurse anesthetist or even the surgeon themselves, like we do in Sittilingi. And the cost of doing general anesthesia is definitely much more than doing it at a spinal anesthesia. And there's no gas needed, and sometimes you can even use instruments, open instruments for some surgeries. So it's amazing. I've been using it also, and it's actually very good for gynec surgeries also, and lower abdominal appendix and all that surgeries. Hello, can you hear me?
We can hear you, Raviana. It's just the slide was
not
slides are not on the
now is it okay?
Now it is okay.
Oh, okay. Sorry, I okay. So this is about the lift laparoscopic surgery. So the newer version of this entire laparoscopic this thing is has multiple parts which can be easily autoclaved and can be assembled by anybody. So the idea is that even in rural areas, we can offer laparoscopic surgeries at a much lower cost. So the next thing that I would like to go to is this situation, which I am sure many of the rural surgeons would have, or even the city surgeons would have faced. This is a child with a coin in the cricopharynx. So traditionally, or in the cities, this would be the procedure that they would do, where a surgeon is where a surgeon uses a bronchoscope to take the coin out. And this needs general anesthesia sometimes, and your bronchoscope and all the fancy things that you would need. Whereas in rural India, we could even do with just a small Foley's catheter, where you just insert a Foley's catheter through the, go past the coin or the cricopharynx, and then inflate it there and just pull it out, and just it comes out. The coin just falls out. So this is as simple as it can be, and I have done it almost 3 or 4 times, and every time it's been successful. So this is as simple as it, but then if we have not done it, it sounds like rocket science. So this is one thing I wanted to share. The next thing I would like to share is using a Foley's catheter. Cut it into small bits, and we use it as bands for hemorrhoids and even for esophageal varices. This is also a thing that we did when during my rural surgery training days, where you could actually load it onto the endoscope, and you could do the esophageal variceal banding also. So the commercial bands that's available are quite expensive, and it's not easily available also. Whereas Foley's catheter is so easily available, and you just don't need any extra equipments also. So this is so simple and such a great idea, I thought, and it's very useful in rural areas. So the last innovation that I would like to share is the laptop cystoscope. This is again developed by Dr. Raj and his team, and this has really simplified what we call the urology in rural areas. Now, for patients coming with a stone in the lower ureter and hydroureter necrosis, where they can't wait for a urologist or to come and do the surgery, it's so easy. You can just put a stent in. So this laptop cystoscope combines the light source, the camera, and they monitor everything together. It's just connected to a laptop, and it's like plug and use thing. So it makes the diagnostic procedures and stenting so simple. So this is the last thing. So why are we even talking about these rural surgery innovations? So there are many more innovations like this, but I would like to say that there are double standards in healthcare innovations. See, all these innovations, if they are good, they should be either acceptable to all in all contexts, or it should not be at all. If it's not of good quality or good standard, it doesn't follow a certain standard. So these double standards, when we actually say, even in BMJ, they published this saying it's equally good, but then we are not using, or it's not commercially, the knowledge is not available everywhere. So these double standards actually raises serious ethical questions, and also makes us think of the power of pharmaceutical industries in dictating the surgical practice. This also leads to a large inequity in healthcare, especially for the poor. So I would like to conclude that as doctors and surgeons, especially, we have a moral responsibility to decide what is best for the patients and not fall for the propaganda of the pharmaceutical industries. Thank you for your time, and for people who are interested to know more about these things, I think I'm just a part of the Association of Rural Surgeons of India, and also the Rural Hospital Network, where you will come across a whole lot of rural surgeons, rural doctors doing amazing work in rural India. Thank you.
Thank you, Ravi Anna, for such a wonderful presentation. And I would think this will ignite a spark in some of the young minds to bring in some more innovations in future. And we'll hope for the best. And thank you all for joining in today. And thank you, and bye-bye.
Thanks, Vibha.
Thank you, Ravi Anna.